Welcome, everybody. My name is Molly Brown. I am the director of the Heartland Telehealth Resource Center. We're glad you're joining us for the HTRC education series focused on telehealth billing, coding, and policy. Just a few notes for you. As you know, this session is being recorded and we will share it with you after the webinar. Your microphones have been muted. Because of the size of our attendance, we ask that you use the chat box to ask any questions. That way we can monitor them and be sure that we follow up if we don't get to them during the webinar. If you would like a completion certificate, please contact us at htrc@kumc.edu. We will be putting that email in the chat box as well. So let's get started. I would like to introduce Rochelle Marting. Rochelle is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. We are thrilled to have Rochelle with us today to talk about care management services. Rochelle, I'll turn it over to you.
Hey, thanks, Molly. Well, today's session, we're going to talk about a topic that in sort of layman's terms, we think of as a telehealth type service, a whole category of services called care management. But one thing I want to emphasize in terms of Medicare benefits, the types of services that we're talking about today are not telehealth the way Medicare defines the telehealth benefit. What that means is a lot of the restrictions that surround telehealth, typically outside of our PHE flexibilities, and as those have been extended for another year, telehealth generally requires that the patient's located in a rural area, presents to an eligible originating site. There's an eligible distant site practitioner. All of those types of rules and restrictions on telehealth services under the Medicare program do not apply to the care management services that we're talking about today, even though we think of these often as a type of telehealth service because they're often not rendered face-to-face with the patient. So we'll talk about today what care management is, what this benefit of care management is separate from the telehealth benefit under the Medicare program. We'll talk a little bit about the coding and the billing and the payment for these services under the Medicare program specific to FQHCs and RHCs. And then I'll go into some of the details on specific care management services. Before I do that, I always want to make an announcement on where we are with some telehealth policies or late breaking news. And one that I want to bring to everyone's attention is that on February 10th, 2024, it is the annual deadline to submit any requests that you want Medicare to consider for services to be added to the Medicare covered telehealth list. They'll take those into consideration as they're developing their proposed rule, which usually comes out in July of each year. Excuse me. You can sneeze. Excuse me. On this slide, there's the link where you can go to submit a request. It's this pretty simple process on CMS's website. They give you instructions, and there's also some really good instructional notes and tips on CMS's website on what they want to see in a request in order for it to potentially be successful. A few things that from provider groups that I've heard from, or things that are sort of on the chopping block in terms of telehealth policy potentially at the end of this year, which as of right now represents the end of all of the telehealth PHE flexibilities, unless something changes, are scheduled to end December 31st of this year. Some of those include frequency limits on subsequent hospital visits via telehealth, frequency limits on skilled nursing facility visits via telehealth. Those have all been suspended for this year, but would go back into effect January 1st of 2025. That's a topic that you could potentially submit as part of this telehealth service request. Services that can be rendered as audio only versus the usual audio visual two-way live real communication. And then any new services that providers want to, well, anybody, it usually is providers, but that anybody wants to request be added to the list of covered telehealth services. Okay, so with that quick announcement, I'm going to talk about care management services, the topic for today, and what care management is. This is a benefit category under the Medicare program that's created not all that long ago, within the last decade of the Medicare program, to describe certain services that may not be completely rendered in an in-person, face-to-face way. But again, they are not telehealth, which means they don't have to be rendered through a live two-way audiovisual interactive telecommunication technology. And in fact, many of these services are rendered sort of behind the scenes, not in a live manner when the patient's not present. So at least part of these services are non-face-to-face. A couple of things to keep in mind too. These are not preventive services. So even though you're not face-to-face with the patient and it's not a telehealth service, co-insurance, patient financial responsibility applies to these services. Everything under the care management benefit category for Medicare has certain criteria, has certain characteristics to them. Care management services involve an initial comprehensive plan of care. And I've delineated out the different components to what constitutes a comprehensive plan of care. This comes from the regulations that define care management and an initiating visit where a comprehensive plan of care is developed. There are certain other qualifications to bill for or provide and bill for care management services. The practice, and in this case, we're talking specifically about FQHCs and RHCs, have to provide 24/7 access to the patient who is being provided a care management service. There's continuity of care with other healthcare providers. You use an electronic medical record. You're engaging and educating patients, and so on. I'll let you read through all of those elements, but these are just core components, core characteristics of any care management service. Now, with all of the care management services that we're talking about, because there are a lot of different types of care management that fit under this benefit category, this benefit umbrella. And one of those is that there has to be an initiating visit with the patient. So that means there has to be a provider-patient relationship established before you begin to provide and bill for a care management service if they haven't been seen within the last year. So that's any new patient, but then also your established patients who have not been seen by that provider or another provider of the same specialty in the same group practice in the last 3 years, would be an established patient. And for care management, you have to have this initiating service to develop the comprehensive plan of care for care management if they haven't been seen within 1 year, not the 3-year period that describes a newer established patient for other billing rules. Now, that initiating visit, it does not have to be comprehensive in the sense of a level 5 evaluation and management service. What we mean by a comprehensive visit or an initiating visit, this could be any evaluation and management code. It could be the Welcome to Medicare, the initial preventive physical exam benefit. It could be an annual wellness visit under the Medicare program. It could be the face-to-face portion of transitional care management. Any of those can be an initiating visit to start the episode of care for a care management service. That initiating visit can be billed on its own. It can be a standalone service for the FQHC or the RHC. And during that visit, a couple of things need to happen. We're developing the comprehensive plan of care for the patient, containing any of as many of these elements as are applicable to the individual patient. But we also have to get consent for the patient to participate in care management, because remember, a lot of these care management services, that are going to be provided are not face-to-face with the patient. They're sort of behind the scenes. They're in between other visits and other services. And the patient's going to be billed for them and have financial responsibility. So it's important for any care management service that the patient consents. Now that consent can be verbal or it can be written. It doesn't necessarily require a full one-page consent form. However, we want to make sure it is documented somewhere, some way, somehow. For example, if during that initiating visit, the provider and the patient are discussing the possibility of care management services that would be a good fit for that patient. We'll look at some of those in just a little bit. That could be chronic care management, behavioral health integration. And the patient consents to participate in that program. The provider can simply document in the progress note that the patient agreed to participate in chronic care management. That's fine. It just needs to be recorded that the patient understands and consented, recognizes that there's a financial responsibility tied to these services. If the provider changes, if the type of care management service changes, maybe from chronic care management to behavioral health or psychiatric collaborative care, that requires a new consent because the patient responsibility amount will be different and the services would be different. So we're going to talk a little bit about coding, billing, and payment for care management services. One of the sort of logistical or technical pieces, because care management is typically rendered over a period of time, usually either 30 days or a calendar month period. There's always the question, what date of service do we use when we're billing for the care management service? Whenever the requirements to bill for care management have been met, you can use that day, the day that all of the requirements are met, as the date of service. You could also use the end of the calendar month or the end of the 30-day period as the date of service for care management. And usually when I say when all the requirements have been met, that's often because care management services involve sort of a running amount of time, an accruing amount of time over the course of the month or over the course of the 30-day period. So once you've reached that time threshold and you've provided all of the core elements for the service, that's when you may be able to bill. The place of service that you report for these care management services, is where the provider would ordinarily render a face-to-face service. So that's going to be your place of service code for the FQHC or the RHC when you're billing those on the claim form. So care management that we're talking about today are specifically services that the FQHC and RHC can bill for separately outside of their all-inclusive rate, outside of their PPS rate. These can be billed separately and paid separately from the standard or as a standalone service. Excuse me. Right now I'm looking at the internet-only manual for FQHCs and RHCs, and you've got a screenshot of the section that talks about care management service billing. And what I'm going to do on the next couple of slides is really dive into this first piece, the types, all of the different components or all of the different types of care management that fall under that one term and that one umbrella. Because something that's unique to FQHC and RHC billing for care management services that's different from fee-for-service billing in a physician clinic is that in the physician clinic, there's about 15 different billing codes that could be used for these care management services. But FQHCs and RHCs, regardless of which type of care management service and what code a fee-for-service provider would be using, RHCs and FQHCs have one code that you report for the care management service, regardless of which specific type it is. So for general care management, we're looking at G0511, and then psychiatric collaborative care specifically has its own code. And we're going to talk about that in a little bit. Now, these can only be billed the care management once per month per patient and can't be billed if other care management services are being billed for the same time period for the same patient. In other words, one per patient per month per RHC, one per patient per month per FQHC. So I'm going to talk about that first type of care management service, general care management. And there are about 10 or 15 specific types of care management that fall under this billing code G0511 that FQHCs and RHCs use. Now the payment amount, I'm going to talk about those specific services. Right now, I'm just talking about the payment amount that you get as an FQHC or as an RHC when you report this code, regardless of the specific care management service you've rendered. Medicare changed the methodology for the payment this year. Previously, the payment amount, the fixed payment amount, was based on the average fee-for-service allowable for each type of care management service. So it was chronic care management, what's the rate? Behavioral health integration, what's the rate? And Medicare took the average of those. But this year, because there's different utilization of different types of care management services, and some are paid at a higher rate than others, Medicare changed the methodology to be a weighted average of each of those rates based on utilization. One of the reasons for that is that remote patient monitoring was added as a care management service in 2024 that can be billed separately for FQHCs and RHCs that has never been part of that care management category previously. And if you haven't already, if you're interested in the remote patient monitoring, we do a really deep dive on those topics for remote patient monitoring and remote therapeutic monitoring in previous sessions that we've done, and those are on the HTRC website. Psychiatric collaborative care sort of has its own bucket. It's its own billing code. I'll tell you about specifically what a psychiatric collaborative care service is. And it's paid at the average non-facility, so more like a clinic than a hospital setting, payment rate. And it can be paid for alone or with other billable services. Click too soon. Virtual communication services is sort of an umbrella term for two types of remote communications with patients. A communication technology-based service, which is sometimes called an e-visit with a patient, and remote evaluation service, which is a patient-initiated communication to share a photo or to share a video with a provider that can be evaluated, and there can be sort of an asynchronous service to a patient without having to come in. So for FQHCs and RHCs, instead of billing what a fee-for-service provider would use as two separate billing codes, regardless of which type of communication service, the FQHC and RHC have one billing code for virtual communication, and it's paid at the average national non-facility, the higher between facility and non-facility. Non-facility is the higher rate for those two codes. So for 2024, here's the payment rates. This is our general care management. We're going to go through all of the services that fall under this umbrella, most of what we're talking about today. Psychiatric collaborative care is also a monthly service. There's the 2024 rate for it, and our virtual communication services. G2025, I should have included that, I believe, is our remote patient monitoring services for 2024. So I'm going to start first with the virtual communication category. You can, the G2012 and 10 are not the codes that FQHCs and RHCs report. That's what a fee-for-service provider reports. You get to combine that, and there's only one code regardless of which type of virtual communication you're providing. And this can be billed either as a standalone service, or it can be billed on the same claim as another billable FQHC or RHC service. And again, our payment rate is about $13.10 for each instance. So the remote evaluation service, the key for this is it's patient initiated. We, the providers, are not reaching out to the patients to initiate this service. Patient starts it. Usually that could be through a patient portal, and there's some sort of consent where the patient recognizes that they might be billed for this service. So patient sends in a video, or they send in a picture, you know, a rash, or the sound of their baby's breathing, something along those lines. And the provider evaluates that and follows up with the patient within 24 hours. The key to being able to bill for this remote evaluation service is it's not related to a clinic visit within the previous 7 days, and it doesn't lead to scheduling an appointment within the next 24 hours or whatever the soonest available appointment is. So this is really designed to be not connected to something that's happened. It doesn't, if it leads to an E&M, then you just end up billing the all-inclusive rate, or your FQHC PPS service. If it truly is kind of a standalone visit, not connected with a visit before or after, or leading to a visit afterwards, then this can be billed separately by the FQHC and RHC. Virtual check-ins, these are sometimes called e-visits. They are asynchronous communications with the patient, and they're also patient initiated. And this is a patient communicating maybe about signs or symptoms, and the intent is to figure out whether that can be managed just through communications with the provider, or if the patient actually needs to come in and be seen. And so when this is truly a standalone service, it's not related to a visit in the previous 7 days. It does not lead to a decision to have the patient come in within the next 24 hours or whatever the next available appointment is. Then G0071 could be reported. Now, generally, this is about 5 to 10 minutes of medical discussion with the patient. And it's by a physician or another qualified healthcare provider. Qualified healthcare provider is not nursing staff. It's not clinical staff. This has to be physician, nurse practitioner, or PA, a provider who is enrolled with Medicare and can bill for services that's rendering this virtual check-in service. So now I'm going to move to, I'm going to go back here. Those fall under G0071. I'm going a little bit out of order here. Now I'm going to jump to G0511, which are general care management services. And this is where a lot of different types of care management that under fee-for-service Medicare billing, each has their own billing code, or sometimes several codes, even for the same type of service. Within this category, all of which gets reported by G0511 for FQHCs and RHCs, is transitional care management. Transitional care management is when a patient is moving from an acute care facility-based setting into a more residential or post-acute setting, transitioning them from one care setting to another. Chronic care management is the monthly management of a patient's chronic conditions. Principal care management is designed to be kind of like the primary care provider's services, principally managing one or more conditions for the patient. It could also be a specialist who's taking the role as principally managing a particular condition for the patient. There's chronic pain management. There's general behavioral health integration. And we'll talk about kind of 2 levels of mental behavioral care management services. Behavioral health integration falls under the general care management. Then there's one that's a little bit more intensive level of service called psychiatric collaborative care. It has its own billing code and a higher payment rate for FQHCs and RHCs. New for this year, RHCs and FQHCs can finally provide and bill and be paid separately for remote physiologic monitoring and remote therapeutic monitoring. There's also two new care management services in the fee schedule for 2024, community health integration and principal illness navigation. Community health integration is really almost like I think of a social worker type function, managing social determinants of health for a patient. And then principal illness navigation is generally for a patient who has been recently diagnosed with a significant illness. I tend to think of oncology as cancer patients as an example. And this is having a resource to help that patient literally navigate the new diagnosis or the new condition. It's helping them with transportation needs and other social determinants of health, community resources, arranging appointments with healthcare providers, giving resources about the condition. So it's really helping them kind of navigate this new condition that the patient will be dealing with. Okay, so I'm going to talk about as many of these services as we can get to in 30 minutes. There's a lot of them, and we could probably have a full hour session on each and every one of them. I'll start with transitional care management. This is where the patient is going from an acute care setting and they're transitioning to a post-discharge location. That acute care setting that they are transitioning from, it could be a hospital, it could be a rehabilitation hospital, it could be an LTAC, a long-term acute care hospital, partial hospitalization, skilled nursing facility, and they're going into a more residential or community setting. So when that transition of care occurs, we follow up with the patient between 7 and 14 days. 7 if there's high complexity decision-making that's involved, 14 days if it's moderate complexity decision-making, and then there are certain things we do as part of that transitional care management. Now, the medical decision-making complexity, moderate versus high, that's determined in the same way that any other evaluation and management complexity level is determined. So you would go to the American Medical Association, the CPT's new medical decision-making table, where you look at the number and complexity of problems, you look at the amount and complexity of data, and then the risk of morbidity and mortality, and you arrive at a medical decision-making complexity. That's the same, this is determined moderate or high in the same way. So part of transitional care management means the provider is reviewing the patient's discharge information from the facility setting they are coming from, any diagnostic therapeutic services that the patient needs, if the patient is to follow up with cardiology or, have an EKG done after they go home, those types of things are part of transitional care management to ensure those things happen. Any coordination of care with other providers or the patient's care team, educating the patient on following up on their discharge instructions. Did they understand them? Going through those instructions and making sure the patient's following those instructions. It might be connecting the patient with community resources. And clinical staff can be involved in the transitional care management service as well, helping the patient with education on activities of daily living. We are reconciling the patient's medications from the facility setting to the community setting that they've been transitioned into. So a couple of pieces on right here in the middle of the screen on coverage rules for transitional care management. This face-to-face visit that is within 7 days if the complexity is high, or 14 days if the complexity is moderate. That face-to-face visit is not billed separately. It has been valued to be part of the transitional care management, this entire 7 to 14 day episode. However, that face-to-face visit can be delivered via telehealth, a true audio or audiovisual live two-way interactive telecommunication can meet that requirement. There has to be medication reconciliation and management no later than the day of the face-to-face visit with the patient within 7 to 14 days of discharge. Only one transitional care management can be billed per patient per discharge. So if you've got a nurse practitioner and a physician in the same practice, only one of them gets to bill the FQHC care management G0511 code. The discharge service in the facility doesn't count as the face-to-face visit for transitional care management. So if your FQHC or RHC provider happened to be the one doing the discharge day management in the hospital, that doesn't count for this face-to-face. Patient has to go home and then come back for a face-to-face afterwards within either 7 or 14 days, depending on the complexity. The transitional care management counts the period of time that's covered by this service is the day that the patient is discharged from the facility setting and the next 29 days afterwards. For FQHCs and RHCs, again, this can be a standalone service that does not have to be billed along with your all-inclusive FQHC or RHC visit, and it's paid separately under G0511. Chronic care management has been around for a while, and now it has been paid separately in FQHCs and RHCs for a while as well. Chronic care management is a monthly service to help patients with multiple chronic conditions. Chronic conditions is any condition that is expected to last 12 months or more for the patient. Some common examples, of course, hypertension, diabetes, asthma, respiratory conditions, COPD, and beyond, but this is not all inclusive. These are just some of the most common ones. Now, I have it here in red because I want to make sure I emphasize I'm putting some codes on this slide that describe the fee-for-service code descriptions. But as FQHCs and RHCs, there's only one code you bill for chronic care management, and that's G0511. Under G0511, under chronic care management, here's all the different types of chronic care management you may be providing. First, there's a comprehensive assessment and care planning by a physician or qualified healthcare provider. This is kind of initiating the chronic care management episode. So this is doc, this is APRN, or this is physician assistant assessing the patient and figuring out what do we need to do to manage that patient's chronic conditions, G0506. That's what a fee-for-service provider would report. You all would be reporting G0511 for that service. The description for the actual chronic care management for 2 or more chronic conditions, okay? Hypertension, hyperlipidemia, cardiovascular disease, COPD, 2 or more with a comprehensive care plan established. So rewind to that second or third slide of the presentation where we have a list of what it means to be a comprehensive care plan for those chronic conditions that are going to be managed. You implement it if it's the first month of chronic care services, or you review, update, revise, monitor that care plan if it's months 2 or after of chronic care management. And in fee-for-service billing, these are time-based, but for FQHCs and RHCs, it's just G0511. But you have to have at least 20 minutes of clinical staff time per calendar month. 20 minutes managing the patient's chronic conditions. So this is sort of a flow sheet. You've got to keep track of the clinical staff time throughout the month. Once you reach 20 minutes, once you have performed all of the other services to review, monitor, revise the care plan for the chronic conditions, that's when you could report it as the FQHC or the RHC using G0511. Now I've bolded clinical staff time, and I also bolded qualified healthcare professional because those are different terms. Qualified healthcare professional means a professional who can bill and receive payment from Medicare, an APRN, a physician assistant. Clinical staff are other professionals who have clinical training. Your RNs, your LPNs, it could depend, as long as it's within their scope of practice, be CNAs and CMAs as well, helping with these services. You could even have contractors if you don't have the resources in-house. Clinical staff doesn't have to be employees either, as long as a vendor that you may be using is still acting under the general supervision of your FQHC or your RHC providers. So I'm not going to go through these in detail, but you will have them on the slides when you send out the specific documentation requirements. The demographics, you have to be using a certified EHR and so on. So when we talk about behavioral health integration, this is a relatively new service, both for fee-for-service billing of physicians to Medicare and for FQHCs and RHCs to be able to bill for this separately as a care management service. Behavioral health integration, it's almost a type of specialized chronic care management in the sense that it's focused on mental or behavioral diagnoses that the patients have. It is not limited to any particular mental behavioral health diagnosis, though. In this model, we have the FQHC provider, the RHC provider. So your physician, your physician assistant, nurse practitioner, clinical nurse specialist, or a nurse midwife. Nurse midwife was just recently added to that list. Typically, these are in the primary care setting, so certainly appropriate in the FQHC and the RHC settings, but there are specialists who can provide these as well. Now, the patient, they're considered to be a member of the care team and part of this model. And clinical staff can help with behavioral health integration as well. So that could also be contractors, just with other just as with other care management services. And with behavioral health integration, there's an initial assessment by the billing provider, by the treating provider at your FQHC or your RHC, the one who has the general overall responsibility for these behavioral health services. They administer validated rating scales. There is no specific rating scale that is required. If you're interested, I can pull some of the examples from the final rule, but they are examples only. As long as it is a validated rating scale for the patient's condition, it meets the requirement. There's care planning. So just like that comprehensive care plan for chronic care management, there is care planning on how we will carry out the patient's behavioral health integration services. And really what they're doing in this model is coordinating among kind of the primary care provider, the patient, and others to help support the mental behavioral health condition. But it is not limited to being used by psychiatrists, psychologists, or other behavioral health providers. In fact, it wasn't even designed to be reported by them. It's designed to be reported really more in a primary care setting to zoom in on helping the patient's mental behavioral health conditions specifically. So RHCs, FQHCs, this is a type of general care management. When it's provided, you report it using G0511. So let's go through some of the specific pieces of behavioral health integration. Because it is a care management service, when your clinical staff or contracted clinical staff, if they're not your employees, are helping with this service, they're doing so under general supervision, not direct supervision, or it doesn't have to be direct. It can be. General supervision is it's less restrictive because direct supervision requires that the billing provider and that clinical staff person are in the same physical location at the time that services are provided, and that's not required. So you could have clinical staff who are working from home, or you could have vendor who's helping and they're not physically in the same location as your billing provider in the FQHC and the RHC. Excuse me. The initial assessment for this service in particular doesn't have to meet all of the elements of a comprehensive care plan because we're not looking at the patient's condition in total. We're focused on a narrow subset of conditions for that patient that are mental behavioral health diagnoses. Clinical staff time spent coordinating care with the emergency department for fee-for-service billing could use 99484. But time spent with the patient in an inpatient setting or admitted to observation status can't be reported as behavioral health integration. The code descriptor for behavioral health integration involves at least 20 minutes of clinical staff time. I've got clinical staff bolded again. Directed by a physician or other qualified healthcare professional in a single calendar month, not 30-day period. We are doing an initial assessment. If it's the first month or a follow-up, monitoring for the patient, we're using validated rating scales, behavioral health planning for the patient, revision of planning for patients who are not progressing towards their goals, usually as determined by the validated rating scales that we're using to kind of measure the patient's status and the patient's progress. This also involves, because there's an integration component to this, coordinating the patient's care among primary care, where we're billing for this service, and coordinating with the patient's psychologist, psychotherapy, psychiatrist and pharmacotherapy, counseling services that the patient has, and then continuity of care with a specific person on the care team. Usually that's a clinical staff member who's in communication with the patient. Okay, now I'm switching gears just a little bit. Those are some of the major, most common types of general care management services in the FQHC and the RHC setting. Now I want to talk about psychiatric collaborative care because this is sort of a heightened, more intensive version of behavioral health integration. And this has its own billing code for FQHCs and RHCs, G0512. Psychiatric collaborative care adds a few components to the model. So we still have our treating and our billing provider. We still have the patient. We still are using validated rating scales. However, we have this two other kind of roles here. Something called a behavioral health manager. Similar to the clinical staff and behavioral health integration, except they're specifically trained in behavioral health conditions in the psychiatric collaborative care model. We have another member of the care team in this model, the psychiatric consultant. And this is typically a medical professional trained in psychiatry who's qualified to prescribe the full range of psychiatric medications. And what that psychiatric consultant does in the psychiatric collaborative care model that's above and beyond what behavioral health integration does is look specifically at the patient's meds for mental behavioral conditions and helps manage those specifically. So under psychiatric collaborative care, we again have an initial assessment. We're administering validated rating scales that are going to help us track the patient's status and the patient's progress. We have care planning for the patient's mental, behavioral, psychiatric conditions. The behavioral health manager, the person who acts similar to a clinical staff person, but in this model, they have specific training in mental, behavioral, psychiatric conditions. Often this would be a registered nurse with some special training. They are proactive in this model. They're following up with the patient, continuing to assess the patient with validated rating scales. They're making sure the patient's following the treatment regimen, medication regimen, coming to appointments, not skipping appointments or canceling, how their patient's tolerating the patient, the medications and the treatment. There might be some brief interventions There might be some motivational interviewing to keep the patient motivated in the care not module, in the care episode, excuse me. So in the psychiatric collaborative care, the psychiatric consultant, the professional who's trained in psychiatric conditions and who's eligible to prescribe a full range of medications, regularly works with the primary care team, in this case, the FQHC and the RHC, and your providers. And the requirement says at least weekly. Reviewing patients' treatment plans, reviewing the status with the psychiatric consultant, with the billing provider. Primary care team might take the psychiatric consultant's recommendations with respect to medications, care plan, counseling appointments, and so on, and implement those. For the RHCs and FQHCs, again, this is a separate code from general care management that you all are billing, G0512 instead of G0511. Okay, so I want to point out again, these are just code descriptors of the psychiatric collaborative care services. You use G0512 regardless of which code a fee-for-service provider would be reporting for psychiatric collaborative care. There could be an initial, there could be subsequent months of psychiatric collaborative care services. And then principal illness navigation. This is a general care management service, G0511 for FQHCs and RHCs. This is a new service under the 2024 physician fee schedule. Under principal illness navigation, these are new codes that were created to help a patient quite literally navigate a new diagnosis or illness. These are used for patients with a serious high-risk disease that's expected to last at least 3 months, that might place the patient at significant risk of hospitalization, might place a patient at significant risk of nursing home, nursing facility care, exacerbation, decompensation, functional decline, or even death. Oncology, for example, is the first one that I think of. In the Federal Register, in the physician fee schedule final rule, excuse me. Some other examples are COPD, congestive heart failure, dementia, HIV, substance use disorder. So the principal illness navigation, they can be furnished to established patients. So a patient who has seen a provider at your clinic or another provider in the same specialty in the last 3 years, following that initial assessment. And the patient has to have at least one serious high-risk condition. We can be helping them navigate multiple, but at least one. The condition requires development, requires monitoring or revising a disease-specific care plan. So unlike chronic care management that's really holistic for the patient and general care management services, this is zoomed in on a single disease of the patient. Unlike behavioral health integration that might be all of the patient's mental, behavioral, psychiatric conditions, this is zoomed in on generally a single serious high-risk condition. So we have an initiating visit for FQHCs and RHCs. That's going to be just your regular FQHC clinic visit, your RHC clinic visit. Then we have the principal illness navigation is a monthly service to help the patient navigate this illness. They can be rendered incident to, which means we can have clinical staff really performing the majority of the principal illness navigation. Incident to, though, means there must be direct supervision. And so when the clinical staff are performing some of these principal illness navigation services, they have to be in the clinic where the billing provider is physically located in order to bill for the service as incident to, instead of personally performed by the physician, the nurse practitioner, the physician assistant. So this is just a description of what the code would look like for a fee-for-service provider. But again, you all would be billing G0511 for this service. The service is by certified auxiliary personnel under the direction of a physician or other qualified billing practitioner, including a patient navigator or certified peer specialist. So patient navigator and certified peer specialist are part of this description. A peer specialist is often a person who has had this particular condition. So they really can sympathize, empathize with the patient who has been diagnosed with a new serious or high-risk condition and help them navigate it. There's a high time threshold to be able to report this code for a calendar month, 60 minutes. So you've got to keep track of everyone's time who are contributing to the principal illness navigation. A person-centered assessment that include any unmet social determinant of health needs. Person-centered assessment, you're understanding the patient's story, their strengths, their needs, their personal preferences and beliefs, their goals, their outcomes with their condition. Goal setting with the patient, supporting the patient, coordinating with community or social resources, coordinating with other healthcare providers for the patients. Really educating the patient, helping the patient navigate the healthcare system, helping the patient build skills to advocate for themselves with respect to their serious or high-risk condition. Now, in the final rule, something that was proposed that was not finalized is in helping ensure access to healthcare system or navigating the system. And while I said that's part of it, it certainly is, but it's not a mandatory piece of principal illness navigation. Helping facilitate behavioral change and really just helping leverage the peer support experience with the condition for the patient, kind of holding their hand through this new diagnosis. Again, these are what the fee-for-service provider code descriptions look like. You all would be reporting G0511 as FQHCs and RHCs for these services. So we have each additional 30 minutes per calendar month, peer support specialist, and the peer support professional in a month. There is no frequency limit for the services described by these codes other than the fact that it's once per month per patient. Not limiting the duration of services. So while the definition is a condition expected to last 3 months or more, principal illness navigation could continue for the duration of the patient's illness. But they did finalize a requirement that there's a new initiating visit to kind of reassess the patient's condition once per year. Doesn't say once per calendar year. Medicare has a funny way of defining time periods, and typically a year means a full 11 calendar months have passed since the service was provided. Any of the auxiliary personnel who are helping carry out the principal illness navigation services have to be certified or trained to provide all of these elements, and acting within their state scope of practice, of course. We have to document the time, just like we have to do for all of these services that are time-based. The time needs to be documented to be able to support billing for those services. Any identified social determinant of health needs should be recorded in the patient's record, and there should be evidence that we are helping meet those unmet social determinant of health gaps for the patients. There's even diagnosis codes. They're in the Z section of the diagnosis code book that can help identify what those unmet social determinant of health needs are for the patient. Those auxiliary personnel who are certified, they can be employees of the FQHC or RHC, or they could be under contract with the FQHC or RHC. Okay, I'm going to pause there because I know we are running up on time. And Molly, turn it back to you for some announcements and then open it up for questions.
Thank you so much, Rochelle, and thank you all for joining us today. As a reminder, the recording and the PowerPoint handout will go out to all of you as soon as we get the recording finalized. Please email us any questions following the webinar today, if any come to mind. There was a lot of information. You can read through the PowerPoint and then also email us anything that you have following that. I will say that as Rochelle demonstrated, we do have an upcoming webinar on February 13th. That is with our licensure expert, Diane Belquist. She will be covering compact licensure changes affecting our region and the new DEA rules regarding prescriptions and how they may impact your practice. We also have our partnership with the National Consortium of Telehealth Resource Centers. They have a webinar every third Thursday, and there is one coming up in 2 days. So we'll be sure to get this information out to you as soon as possible. And that webinar will be covering what to expect with policy changes at the national level in 2024. Are there any questions? We will be anything regarding our certificates. Yes, we've marked it. If you've requested a certificate in the chat, we have marked your name down. We will get that to you shortly. Again, thank you for your time, and please email us your questions and we'll get your responses to you very shortly. And I appreciate your time and look for our email. Thank you, Rochelle.
Thank you.